Next up, we have Dr. Kristina Jülich. She is a neurogeneticist in our department. She trained originally in Germany. I can't pronounce her medical school, but I can translate it. It's Charity University Hospital. I love how elegantly that's laid out there. And so, and then she repeated training here at Boston Children's for child neurology and genetics. And then has worked here for several years and building up our neurogenetics clinics. So she's going to talk to you all about neurogenetics.
Thank you, Dan. So it's Charité Universitätsmedizin Berlin. But okay, yeah, so thank you for coming and thank you for inviting me. As Dan said, my name is Kristina Jülich. I'm the chief of the Neurogenetics Center here at Dell Children's, and I wanted to talk a little bit about neurogenetics and what we do. So I have no relevant disclosures to this talk. I wanted to first introduce our Neurogenetics Center a little bit and explain what we do, what our goals are. I'll talk a little bit about the basics of genetic testing, and then also what are the benefits of genetic testing? Why are we actually doing that? And so first, our Neurogenetics Center is currently still relatively small. It's me and Reina Lobo, who's a fantastic genetic counselor. We're just in the process of hiring our second genetic counselor, who will hopefully be starting this fall. So we're definitely growing. And what do we do on a daily basis? So we have about 1.5 clinic days of neurogenetics clinic currently, and the majority of what we do is genetic counseling and diagnostic workup. So typically what happens is that our colleagues or sometimes one of the primary care providers will refer a child who they're suspecting genetic etiology for autism, epilepsy, developmental delays, will refer them to us. Sometimes they will have had prior genetic testing, sometimes they've had none. And then we get all the records, look at everything. If the genetic testing has been negative, the prior testing, or none has been done, we'll recommend further testing. If it came back with a positive result, we'll counsel the family on what that means and provide resources. And if the prior report was non-diagnostic or was unclear, essentially, we try to interpret those results for the family and make recommendations on what to do next. The other things that you see on the slide are our program goals that are in various stages of development and progress. So clinical trials in the field of neurogenetics are, and genetic medications, so molecular medications, are, I think, in our field, the medications of the future. You probably have all heard of the FDA-approved medications, gene replacement therapy, and the ASOs for SMA and Duchenne. And so for other conditions in our field, some genetic causes of autism, some genetic epilepsies, those medications are being developed, and those trials are either already running or are starting soon. So we're hoping to become a trial center for some of them soon. We're involved in an epilepsy outreach project where we aim to improve neurogenetics care, so genetic workup for kids who live in more rural areas of Texas. We're working on building protocols or algorithms for genetic testing in kids with various types of neurologic conditions. We're hoping to be looking at health outcomes. So how does a family or a child benefit from a genetic diagnosis or the workup that we're doing? And then last but not least, and I'll get back to that point, we're doing teaching. And so a little bit of a jump. So genetic testing, what kind of tests can we order? There's many more than available than I put on the slide, but what do they actually look at? So largest structural genetic chromosomal abnormality would be a monosomy or a trisomy. Those are conditions that you can diagnose with by ordering something like a karyotype, or a microarray will capture most of those as well. We in neurogenetics almost never order a karyotype. Those kids often have multiple associated malformations, and they will be diagnosed either during pregnancy or shortly after pregnancy by genetics. So it's very rare for me to send a microarray and to suspect an undiagnosed trisomy or monosomy. But the bottom two is essentially our daily bread and butter. So that's what we order and interpret every day. And there are two sort of different, I think Dr. Brumbeck has briefly referred to them already. The first one is what's called a copy number variant. So largish structural aberration on the chromosome, too small to be seen on a microscope, too small to be captured with a karyotype, but it's essentially a larger amount of base pairs missing or being duplicated. And so that's something that is actually the most common genetic cause for autism and global developmental delays. It's also the first-line test you would order if you see a child with multiple congenital abnormalities or a complex brain malformation, and complex non-specific brain malformation. And for that test, you would order something called a microarray. It can be detected by exome or genome sequencing, but microarray is actually more sensitive for some of those than an exome. And then if you go into even more detail, you're looking at single base changes or very small duplications or deletions. You would be doing sequencing. And so I'll explain in a minute what next gen, so NGS stands for next generation sequencing or massive parallel sequencing. You've probably come across this term. And those are the sequencing tests that we do. Single sequencing has largely fallen out of fashion because it's just not cost effective. We've learned that there's so much variation in genetic disorders that it's almost always more cost effective to order a gene panel, and then whole exome and whole genome. Sanger sequencing is also only reserved for very specific situations. And so what is an exome and what is a genome, and what do we look at? So whole exome sequencing refers to sequencing the coding regions of our DNA, of our genome. So a whole exome sequences the exons of each gene and maybe the intron-exon boundaries. So that's what gets transcribed and then spliced into messenger RNA and later on translated into a protein. So it is, if you're thinking about neurogenetic conditions, it's certainly a very important part of our DNA. But if you look at this example with the apple, it actually only looks at about 1% of our DNA. So it's nowhere near a complete look at our DNA. Whole genome sequencing, in contrast, will look at everything. So you might wonder, why in the world would anyone order an exome over a genome? I mean, for one, insurances in Texas do not pay for genomes yet. That is one, and we still don't, so genomes are clinically available now. They're being offered by labs. We still don't know very well how much higher the yield of a genome over an exome is. And as I said, the exome does cover the regions of our DNA that are probably most relevant for genetic disorders. The yield of a genome is most likely going to be higher than exomes, but we don't really have that data yet. So how do they work? microarray versus next-generation sequencing. If you order a microarray, or sometimes it will be called array CGH, what the lab does is they will essentially chop up the patient, isolate and chop up the patient's DNA and label the little pieces to a fluorescent dye, so it's green here in this example. And then on the other hand, they have a reference library, so a healthy person's DNA also chopped up into little pieces labeled with a red fluorescence dye. And then they will hybridize, mix them essentially, and hybridize them onto this chip plate. And so the chip plate, every little well that you see there, is coated with essentially a complementary binding strand. So you know exactly which piece of DNA is supposed to hybridize where. And so in the world of fluorescent dyes, red and green together equal yellow. And so if you have same amounts hybridizing onto the plate, so both the control and your patient have 2 copies of each, it will come out as yellow. If you have a deletion, the patient has a deletion, less of his DNA will hybridize and more of the control DNA will hybridize, and it comes out as red. And if he has a duplication or she has a duplication, it will come out as green. And so that's read out, and then you know exactly what the copy number variant is. Next generation sequencing, on the contrary, you have the patient's DNA that gets chopped up into little, very, very small fragments, 20 base pairs, amplified. Then you have a little adapter ligated to it, and then it gets sequenced. And so you end up with thousands of little 20, 25 base pair strands of sequences that then are realigned again to form one sequence using a computer, essentially. And so that is much faster and much more cost-effective than doing Sanger sequencing, where you sequence one long strand after the other. So that's why it's called massive parallel sequencing. So just brief nomenclature. We try, even though you've probably heard me say that, we try not to say mutation anymore. We use variant instead, and then that variant gets classified. So either pathogenic or pathogenic, those are the mutations, the disease-causing variants. Benign variants, those are very common. They may be present in 5% of the healthy population. So another word for them is a polymorphism. And then we have the variants of uncertain significance, which essentially means we just don't know. It could be disease-causing, could not be. We don't know yet. And so I have a sample report here for you. I don't know if you can, might be hard to read, but this is essentially what those reports look like. You've probably seen them in your clinical practice. It will first say, they all look pretty similar. I don't know if we have a pointer or there a little bit. So it will give you the results. So it will either say negative, positive, or uncertain if we don't know. Then it usually says the gene name here, the position, and what kind of change it is. So in this case here, this is just a sample report I downloaded. It's not an actual patient. It says intronic, so it's not in a coding area. The zygosity is important, heterozygous. So we all have 2 copies, except for X and Y chromosome. We all have 2 copies of each gene. If it's heterozygous, that means it was only found on 1 copy, one of the 2 alleles. And so that is relevant because if it's a recessive condition, even if it's a pathogenic variant, so a mutation in a recessive gene makes you a carrier, right? So it's important for interpretation, and then how they classify it. And then usually we look at the next page where it will give you some clinical information. So it says this gene, in this case, is associated with dominant and recessive conditions, which makes it more difficult. It will tell you whether they're offering to test the parents for free. So they must always offer this if it's a dominant condition, thinking that, you know, if this change was inherited from a healthy parent, it's less likely to be relevant for the child, and we almost always order that if it's offered. And then the lab tells you why they classified it as uncertain. So they will tell you how conservative is that position, essentially. And here, in this case, they're thinking, you know, well, yes, it was intronic, but it probably affected a splice site. They will tell you, is it present in the healthy population? keeping in mind, what they don't tell you is that these population databases heavily rely on people of Caucasian ancestry, so they're not very representative of the general population. Whether this variant has been seen in anyone with similar symptoms doesn't necessarily mean it's causative, could just be an association. And then they run computer models that allow them to predict whether this could be damaging to the protein. And so Raina and I take all of this information, do a lot of literature research, and then sort of provide a family with our own interpretation, whether we think this is likely irrelevant, this is more likely relevant, or whether we just don't know. And if we just don't know, what we'll often do is we'll say, let's revisit this in a year or two, because we are learning more about this gene, and it's very possible that in a year or so we'll be able to classify this to pathogenic or not, or benign. I just wanted to talk a little bit about epilepsy genetics, which is my primary focus. So 50 years ago, I think we knew, and long before that even, we knew that epilepsy, there was something genetic about epilepsy. Epilepsy tends to run in families, but we just didn't know what it was. It was called idiopathic, right? You have 20% or so of acquired epilepsies, and the remaining 75-ish% were referred to as idiopathic. And that word idiopathic remained for a long time. And that's one, on the bottom is one of my favorite quotes about epilepsy genetics. So in the 1990s, when we still didn't know of any epilepsy genes, Gardner said, "Whoever described diabetes as the geneticist's nightmare had evidently not given due consideration to any claims the epilepsies have on this title." Okay, so things have changed since then, although it's still true to a little bit. So nowadays, when we do genetic testing in kids with epilepsy, the yield of genetic testing in all childhood epilepsy is somewhere between 15 to 30%, the yield of finding a genetic cause for the epilepsy. And that varies hugely depending on comorbidities, depending on the age of onset, and depending on the type of epilepsy. So, for example, if you have epilepsy, unexplained epilepsy, starting in the first year of life, it's almost always genetic, monogenic, and you're very, very, very likely to find a cause. In comparison, the later onset epilepsies, such as childhood absence epilepsy, that is easily controlled with one medication, the likelihood of finding a genetic cause is much lower than that. So nowadays, I made this figure a few years ago, but it hasn't changed that much since. So idiopathic does not exist anymore. Like, that's the one take-home message about epilepsy genetics. There's no such thing as idiopathic epilepsy. There's always a cause. We may not be able to identify it yet, but there's always a cause. So we still have about 20% or so that are acquired, and the rest is related. All those idiopathic epilepsies are related somehow to changes in our DNA. They may not all, or they're not all monogenic. So the monogenic ones are the ones that we can test for with those panels. One mutation in one gene causes epilepsy, and we can may be able to identify it by genetic testing. Somatic mutations, so mutations that are not present everywhere in the body, but probably just in a few cells in your brain, few neurons, we can't really test for yet. And then the large, probably, at least 60, 70% of unexplained epilepsy is much more complex. So polygenic, not one mutation in one gene, but multiple changes in multiple genes. That's where the research is going in that field, but we have no way of testing yet. Why do you need a genetic diagnosis? Why is that important? Do we have, is that going to change treatment? So obviously the first thing you think, and families, the first thing often that families ask is, well, do you have a medication? If we do the testing and you have an answer, do we have a medication? Most of the time we do not, unfortunately. Precision medicine is becoming more important. You sort of see a timeline here. If you put this into midline, precision medicine and neurology, almost done, getting the 1 minute sign here. And neurology, especially over the past few years, number of publications has like this, but most of the time, we do not yet have a medication. However, it does often change our management recommendations, even if it might not be a medication. Sometimes we know, oh, children with this genetic condition, 5% of them may have a heart defect, so let's do an echo, or those kinds of medication, those kinds of management recommendations. Publications have come out recently, and I think that's important if you want to get testing approved through insurance. Let's say in epilepsy, it has led to changes in 1 to 2/3 of patients where they found a diagnosis. And if the medications were changed, it led to seizure improvement in 65%. That's probably largely related to diagnoses like CN1A, where you'd avoid sodium channel blockers. In many of the ultra-rare genetic epilepsies that we see every day, we might not be able to make that recommendation. Let's change a medication, or we need to look for something else. But there's so many other things that are important for a genetic diagnosis, and that's what we talk a lot about with families. So for one, it ends the odyssey, right? I mean, there's so many families where the parents blame themselves, especially the mothers blame themselves. It was something during pregnancy, something during birth that went wrong. And so to be able to give them that answer is huge. It allows for rare disease advocacy. It's been shown to reduce travel costs and stress for the families. It definitely helps access services if you have a genetic diagnosis. It enables anticipatory guidance, so to be able to tell the family, it's a neurodevelopmental disorder, it's not a neurodegenerative disorder, is huge. And then last but not least, it helps them find a community. So no matter how ultra rare the disorder is, even if in the literature you find 2 handful of patients, there will be a parent Facebook group somewhere out there. And so what we usually do is when the families come to clinic, we provide we prepare a little folder with the test results, with everything we can find about that condition, with the Facebook group information. Nowadays, there are also matchmaking websites for genetic diagnosis, essentially, that allow you to match with other families with children who have the same genetic condition. So I think that for me is right now, for these ultra-rare conditions, one of the most important things to help create that community. And so very last, I know I'm a little bit over, I just wanted to get back to the teaching part. So I think genetics have become incredibly important in child neurology, and I think it's important that everyone has a basic knowledge about genetics, and I would love to do more teaching or work on teaching projects. So if there's anyone out there of the primary care providers who would like to work on that and help us think, how can we improve awareness for genetic disease, but also knowledge about genetics, please feel free to contact me. And I have my contact information on here. Thank you.
Quick question, maybe. So I think it's interesting in the adult PCP world, there's been this kind of rise of genetic testing done in office in like internal medicine and family medicine practices. Meanwhile, we actually have better evidence for it in pediatrics, and the AAP writes the guideline for testing for autism and global developmental delay. What role, I guess currently, how much do you think microarrays are ordered in pediatrics offices, and to what extent should pediatricians feel comfortable with that?
That is an excellent question, and I think that's something that I would love to explore more, because so the guidelines, I think genetic testing is going to enter routine clinical practice for sure for the epilepsy. I mean, the guidelines say everyone with epilepsy should go genetic testing, right? Everyone. The question is it feasible? And even if you are able to send the test, insurance approves it, or it's a test offered free of charge, you also need to know how to interpret the results, right? Because they're not always clear cut. And that's right. That's the tricky part, and I think that's where the work needs to be done. If you order a test, you need to know what to do with the results. And so this is the tricky part that we're struggling, because genetic counselors are hard to access. Some of the labs offer sort of online, virtual counseling, but I think that's really what I would like to explore. Like, how can we educate providers to increase the knowledge about how to interpret those reports? Thank you.